For squamous cell cancers, squamous cell lung cancers, we don't have any actionable alterations to allow oral therapy. So typically the biomarker that we would test outside of a clinical trial would be for PD-L1. And if the PD-L1 is very high, then it would be reasonable to treat with pembrolizumab alone. So when the tumors are really inflamed with really high PD-L1 scores, 70, 80, 90, 100%, single agent immune therapy can be highly effective with minimal toxicity. For the rest of the patients, I think that some sort of combination therapy is indicated. So KEYNOTE-407 was a large randomized phase 3 trial that compared standard histology-based chemotherapy with or without pembrolizumab. And it clearly showed that the chemo-IO combination was superior to chemotherapy alone, with a modest increase in toxicity. So, and certainly an important new standard of care. In that same squamous cell population, we now also have the Checkmate 227 regimen of nivolumab and low-dose ipilimumab, and also the Checkmate 9LA, where we have an FDA approval for 2 cycles of chemotherapy plus nivolumab and ipilimumab. So I think that, to summarize, sort of in this metastatic squamous cell population that doesn't have active autoimmune diseases or some other contraindication to immune therapy, it would be consideration of single agent immune therapy for the really inflamed tumors with a high PD-L1 score, and then some type of combination therapy, either standard chemotherapy plus immune therapy or nivolumab, ipilimumab, with or without 2 cycles of initial chemotherapy, depending on the clinical circumstances and the preferences of the patient.
The IMpower 131 regimen is a randomized phase 3 trial looking at the addition of the PD-L1 inhibitor atezolizumab to taxane and platinum-based chemotherapy in patients with treatment-naive squamous non-small cell lung cancer. This was a large trial, over 1,000 patients, with a 1-to-1-to-1 randomization. Chemotherapy alone using carboplatin nab-paclitaxel, carboplatin nab-paclitaxel and atezolizumab, or carboplatin and paclitaxel with atezolizumab. What we saw when we look at the results from this trial, that the addition of atezolizumab to carboplatin nab-paclitaxel did improve progression-free survival from 5.6 months to 6.3 months. But there was not a significant improvement in overall survival, from 13.5 months with chemotherapy to 14.2 months with chemotherapy with atezolizumab. Now in the PD-L1 high subset, the hazard ratio was an impressive 0.48, but it was not formally tested, study not designed to look at that subset specifically. There were no concerning safety signals, and it was relatively comparable to other strategies, but in a setting where we have other regimens that have FDA approval and a clear survival benefit, the atezolizumab carboplatin nab-paclitaxel regimen from IMpower 133 really not having a big clinical impact.